Good morning, everyone. At the outside, my sincere thanks to the organizers for the invitation. I'm happy to be a part of this event. As chairperson said, stress is a part and parcel of our profession. Whether you are an embryologist or a clinician or a patient, you tend to experience stress at different part of the time of treatment. But I'm not expert to talk about this stress. I restrict myself to the stress experienced by the gametes and embryos and how it is going to impact on the outcome. So this is the outline of my presentation. I start with the biology of response to the stress and how the embryos and gametes respond, and then what are the laboratory factors, and then how we can mitigate this kind of stress in the lab. So from the clinical lectures to, I'm going to take you through the embryology lab. As we all know, we deal with very unique cell types in the lab. The sperm, oocyte, and embryos, they're different, not only with respect to their structure, they're different with respect to the chromatin architecture, with respect to their ploidy status, the epigenetic signature, their metabolic process, and their antioxidant defense. Because of this difference, their ability to experience stress and respond to stress is also different. For example, if you look at sperm, we know that sperm is a very simple structure, it's a small head and it's a tail and easy to handle, but the sperm has a very complex structure built in. As we all know, the histones are the backbone of any chromatin. As you see here, there are some histones. They are backbone of any somatic cells. But in spermatozoa, the histones are completely replaced by protamines. The protamination is very important for the sperm to attain its compactness and its ability to penetrate the cumulus cells and zona pellucida. But if the process is not completely done, if there is a retention of these histones, it can compromise the fertilizing ability. This can also impair the functionality of the sperm. Probably it may also affect the pregnancy outcome. With our own data, where we have found that the differential sperm histone retention can affect the epigenetic signature in spermatozoa and affect the outcome. So this is particularly important when we see a normal semen analysis, when the profile everything above the WHO reference range, we just name it as idiopathic. Because it is not idiopathic, we have not understood the pathology which is compromising the fertility. Another most important topic which is being discussed these days is sperm DNA fragmentation. We all know that the sperm DNA fragmentation is multifactorial. There are many reasons for DNA fragmentation. In fact, this is our own study we published about 15 years ago. We have shown that the men who are above 40 and who have poor quality ejaculate tend to carry higher level of DNA fragmentation. It's about 16 years old report. There are more than 10,000 publications in the last 15 years on DNA fragmentation. But if you look at the publications, we do not know what is the right way for testing the DNA fragmentation. We do not know what is the threshold which can consider clinically relevant. And we do not know what is the impact of DNA fragmentation on the outcome. So it is considered that the sperm, because of its resistance, it acquires the DNA fragmentation in the post-testicular level during its epididymal transit. Because that's the reason many people practice with the high DFI, they try to retrieve sperm from the testes and then use it for ICSI. That is fine, but as I wanted to tell you here is that the DNA damage is acquired during its epididymal transit because of the stressful environment in the epididymis. There are many reasons. It could be because of the chromatin architecture is not poorly developed, or it could be because of the oxidative stress. Epididymal environment is not conducive for sperm. Maybe it is creating oxidative stress and eventually compromising the ability of the sperm. So it is now known that the damage or the stress which are caused also due to the manipulation. It could be before analysis or during semen analysis. There are many reasons, maybe the abstinence or how the samples are collected, how they are transported, and in the lab how they are handled and the technique used. All these can eventually can lead to stress and compromises the epigenetic or genetic integrity of the sperm. And it's also important to know that the poor quality ejaculate are more vulnerable, susceptible to experience stress in the lab. In fact, this is our own study. We wanted to see whether the epididymal transit is anything to do with the quality of the spermatozoa. We have done it. We looked at a retrospective analysis done about 10,000 patients, looked at the impact of ejaculatory abstinence from 0 to 15 days, and we have shown that the short abstinence is better. If you allow sperm to stay in epididymis for a short while, you tend to get good quality spermatozoa. There are many reports, but the flip side of this is the sperm which stayed in epididymis for a short while may have compromised ability to retain its genetic intactness. This our own data. Again, what we did was we compared the ejaculate of different abstinence from 1 day to 7 days. We collected the ejaculate and processed it, and then we looked at the DNA fragmentation after 6 hours and about 24 hours. These are data from 3 days abstinence. Looked at 6 hours after wash, we found about 3-fold increase in the DNA fragmentation. 3-fold, it's not percent. At the end of 24 hours, the DNA fragmentation level rise to close to 7%. The problem is here, with the short abstinence of 1 day, the processed sample within 6 hours, the DNA fragmentation level rise to 20-fold. At the end of 24 hours, it is 40-fold increase in the DNA fragmentation. This is particularly important if the sample is going to be used for insemination, because fertilization may not happen immediately. Sperm has to wait for the oocyte to come. If the duration is prolonged, the genetic integrity or the compactness of the DNA is compromised. The DNA longevity is compromised, the short abstinence. If you are doing for ICSI short time, it may not be a problem. With the prolonged fertilization or insemination, probably it can affect the outcome. When we look at the oocytes have a different way of experiencing stress and respond to stress. GV oocytes from the antral follicles cannot induce any kind of stress response. So if the follicular environment is also stressful, they don't show up any kind of response. They keep growing. For example, here, as what I show here is that if the follicular environment is not conducive, maybe because of the supraphysiological administration of the hormone, if the environment changes, high estrogen, it may not have any impact on the oocyte. It keeps growing. It can even proceed from GV to GVBD. The GVBD can happen, but when the oocyte reaches metaphase 1 stage, it realizes that it had experienced some suboptimal conditions in the follicle, could be exogenous or endogenous, and then stop progression. This could be one of the reasons for seeing heterogeneity or seeing more number of M1 oocytes in your stimulation in your program. And if the oocyte can fix this damage, after some time it progress, can lead to healthy metaphase to oocyte. Similarly, the human embryos are very unique with respect to their ability to grow. From single cell, we get blastocyst on day 5. A lot of changes happen during the development. There are changes in the degradation of the maternal transcript, initiation of the human genome. There is a shift in the metabolic process. There is a shift in epigenetic aspects. There are multiple changes happen during the pre-implantation development. What I want to tell you here is that the human pre-implantation embryos also have a limited ability to sense. They have the ability to sense, but they do not have the ability to respond to the stress. That's the reason if you see a beautiful embryo on day 3 without any fragmentation, doesn't mean that it's a healthy embryo. It must have experienced some kind of suboptimal condition, stress, and it starts showing up the response when it reaches the blastocyst or later stage. The checkpoint, we call it as checkpoint system. The checkpoint systems in embryos become fully functional post-compaction, and finally there are different mechanisms. I am not going to explain all this, But finally, we consider apoptosis as a fail-safe strategy to eliminate abnormal cells in the embryo, and if all good, we get successful pregnancy. If the damage still persists, if it cannot be eliminated, then probably it can affect the implantation. If the implantation happens, it may eventually lead to post-implantation demise, and if the risk is higher, probably it can increase the risk of birth defects. Let's come to the factors, the laboratory factors which can cause stress in gametes and embryos. There are multiple factors. It could be thermal, it could be osmotic, the chemical, or oxidative factors. Sometimes these factors are combined. They are not together. I mean, they work together. For example, here, as you know that once a sample is received in the lab, ejaculate is received, we start processing it. Once the seminal plasma is taken out, the protective shield is gone. Then we pipette the sperm, we centrifuge them, sometimes even cryo-freeze thaw them. We create all kind of stress to spermatozoa. It eventually raises the ROS and can compromise its DNA integrity. The second, our own study, we published long back, about 15 years. We wanted to see the impact of cryopreservation on the sperm DNA integrity in patients with teratozoospermia. 15 years ago, the reference value was 30%. Now we have less than 4%. The 4% is the reference value. So what we found is that morphologically abnormal sperm has increased susceptibility to DNA fragmentation post-warming. Since our reference values have come down less than 4%, we have more and more patients with 0%, 1% morphology. We can imagine the outcome may be much more serious these days. So we have to be more cautious while dealing with this kind of samples. It's not only this kind of the stressful interventions or mechanical interventions. Exposing the sperm to PVP. PVP is an important substance for ICSI. Without PVP, we cannot manipulate sperm. Exposing the sperm to PVP for more than 30 minutes can also create stress and can create DNA fragmentation in the spermatozoa. This again our own study. What we did was we subjected the process fraction of the severe oligozoospermia patient, subjected to PVP, and at 30 minutes you can see a very high level of DNA fragmentation compared to non-PVP. I am not referring what non-PVP we have used, but PVP per se can also create in situ DNA fragmentation. Since there is no check at this stage, we select sperm and perform injection. That means there is a risk of selecting the sperm which has DNA fragmentation, eventually using it for injection. So ICSI has become very popular. Without ICSI, we cannot survive. Even if you look at the global data, the ESHRE data, the 2/3 of ICSI cycles are now, ART cycles are ICSI cycles, though the outcome is slightly higher with IVF, because we know that ICSI, we bypass all natural selection process and we create more stressful environment, though we are now moving towards automation in the ICSI, which gives more precision during injection. But it is not only performing injection, the process of preparing the gametes for ICSI, like denudation, the sperm preparation, dish preparation, needle placement, oocyte washing, these processes can create more stress to gametes. If they are not done in a right way, not done under a controlled condition, they can create more stress and eventually compromise the outcome. So if you look at a nice review published by David Gardner, who said that the IVF lab is the most important factor which can influence the embryo phenotype. It could be machines, it could be people, it could be environment. They do influence the embryo phenotype. So it's very important to look into these factors and see how we can prevent the impact of the suboptimal conditions on the outcome. Let's look at the embryo culture media. Today's culture media, we have different types of culture media in the market. Some are one step, some are sequential, but most of the time we do not know what they contain. They are secret, they don't reveal us. And if you look at the literature, there is no evidence on the superiority of one medium over the other medium. People also go with the 3 days, 5 days, 6 days, 7 days culture. I am not here to discuss about the advantages and disadvantages. What I want to tell you here is that whatever we do, we should do it according to the requirement of the gametes and embryos. We should not just follow the protocol blindly. Another important point which I would like to discuss is about the oxygen. We all know that the embryos in vivo are exposed to or I can say low oxygen tension, maybe from 2% to 8%. Then why should we expose embryos to high oxygen? So in an embryology lab, we know that if we use a traditional box incubator, we expose them to 20%, which is very high for embryos, because embryos are developed in a low oxygen tension, and high oxygen tension can be stressful because it can also induce the senescence. The senescence means embryo morphology does not change, but embryo loses its viability, so which is also not a good sign in the embryology lab. So we have in the modern ART lab, we have all state-of-the-art machines which can give us low oxygen. The nice gadgets can give controlled oxygen. So the reports so far have shown that low oxygen is superior compared to high oxygen. 20% is ambient. Some people use 5%. The monophasic, some people also use biphasic. They keep first few days at 8%, then shift it to 5% oxygen, try to mimic in vivo condition. In fact, there are studies. In fact, we have done a study with our collaborator in Slovenia, where we expose them to 8%, 5%, and 2%, trying to see whether that can improve the outcome. But whatever we do, we cannot mimic the concentration gradient which is seen in the female reproductive tract. And interestingly, we did not find any great result with this approach. Another important technique which is commonly used in IVF lab is cryopreservation. It's a part and parcel of our system. The cryopreservation is the process where embryos are exposed to all kind of stress. We take the embryos from 37 degrees centigrade from the incubator, we bring it to room temperature, suddenly we drop them to minus 196, and we give an osmotic shock from 280 milliosmol to 5600 milliosmol, and we attain a very high cooling rate to get better outcome, up to 25,000 to 50,000 degrees centigrade per minute. Though we get excellent outcome, good pregnancy, we do not know what kind of impact these manipulations have on the progeny. So what can happen? There are such studies which show that there could be epigenetic disorder. I am sure there are reports with the higher incidence of the epigenetic disorders in the ART-born children. There is a risk of cancer, birth defect, and obesity. But again, it's very controversial. There is no evidence that which technique per se can induce which kind of normality. But there's a nice study which is published, is quite old one, by the Australian group. They looked at 300,000 ART-born children, and they compared with the spontaneous one. They found that the risk of birth defect in ICSI-born children are slightly higher compared to the spontaneous one. This our own data is a meta-analysis, a systematic review published last year, and our data has also shown that ART conceived children have a marginally higher risk of congenital anomalies compared to the control group. So why does this happen? What are the reasons for this iatrogenic stress? Primarily because of three reasons. One is inadequate infrastructure, inadequate staff, high volume of patients. Suppose you do it in batch. Some centers do follow the batch IVF. Suddenly you have to handle too many patients, but your lab is not well prepared. You have only one small incubator or only one embryologist. This can increase the risk of stress and eventually affect. Apart from this, no SOPs in the lab, lack of scientific knowledge by the embryologist, use of untested technology, material, or it could be the negligence of the embryologist or ignorance. All these factors can lead to stress. So let's quickly look at, if I have time, it'll take 2 minutes to go through the strategies to de-stress. According to me, these are the 5 important pillars which can help in mitigating the stress. Apart from the competency of the embryologist, we should have good quality management system, good SOPs in place, KPI, and importantly, the good ethics. KPI, now if you look at the Cairo consensus, which says that everything in the lab is important. Every factor should be looked into. It's the big list. We cannot ignore anything. I'm not going to discuss in detail. The SOP, the standard operating procedures, many of us don't have standard operating protocols. Even if we have, they are not updated, maybe about 5 years old, 10 years old. Embryology is a rapidly developing field, and what we see today become obsolete tomorrow. It's very important to look into our protocols and improve it. For example, if you look at do ICSI, we don't have a protocol or established or recommended protocol how to do ICSI in a right way. In the same center, one embryologist selects one sperm under high magnification, carefully, go to one oocyte droplet which has only one oocyte, injects. The other person in the same lab takes 20 sperm at a time, goes to a droplet, has 20 oocytes, finishes ICSI in same time. I am not here to debate what is right or wrong, but whatever we do in the lab should have evidence. For example, if you look at SOHO regulation in Europe, which recommends how the tissue should be handled for cryopreservation, recommendation by HFEA in UK, which says that, okay, to use adjuvant, you go with the evidence. If there is no evidence, it is not advised. I mean, they are very particular about if there is no evidence, don't use it in the lab, because for many things what we use in the lab, there is no evidence that they can improve the pregnancy outcome. So we have also tried our way by using some adjuvants. We tried some micronutrients and vitamins, biotin, supplementing them to culture medium during cryopreservation, during preparation, see whether that can mitigate the stress and can improve the outcome. Yeah, in some of them have shown some improvement. We are going towards the microfluidics. Microfluidics, people say that it's good. In fact, I also like this because it is more of natural selection. Go with the chemotaxis, thermotaxis, and rheotaxic mechanism. We have now gadgets which give even better numbers. Earlier, that was the problem. It used to be good only for ICSI because we can't retrieve more sperm, but now the new multi-channel one, we can even get higher number, which can even be useful for therapeutic inseminations. This is our own approach. We used the old concept of migration sedimentation. It's a very old concept. This is a prototype where we devised it, and you keep the ejaculate here, overlay with the medium, incubate. It's good for office IUI. After 1 hour, you take sperm directly from here and inseminate it. You can even get more than 5 million good quality sperm with good morphology and less DNA fragmentation. Compacting embryo manipulation. As we know that the day 4 is the most crucial stage in the human development where the compaction happens. The compaction is very sensitive phase in the human development because cell-to-cell connection happens. That's the time segregation of the cells in 2 different compartments. That's the reason embryo should be undisturbed on day 4. No manipulation, no freezing, no transfer. If you look at literature, there are not many papers did embryo transfer on day 4. No freezing on day 4. You may ask me, I have done it, I got pregnancy. Yes, you may get pregnancy, but you do not know what's the impact of the child after 1 decade or 2 decades. So when we know that it is not physiologically right, we should not do this in the lab. But now we have great technology. We have non-invasive PGT. We have time-lapse system. We have AI. I'm sure these technologies, which are used in a right way, they can help in selecting the competent embryo without affecting or without stressing them. The last factor I would always say is the embryologist. The embryologist is the biggest stressor. If the embryologist is not doing things in a right way, he or she can be more stressful to the lab. There are many reasons why embryologists are stressed. It could be because of the difference in the skill, the competency, or lack of skilled embryologists. Probably there will be only one embryologist who has skill have more stress. He has to do a lot of things. It has been shown that apart from this, because of the working overtime, or maybe not able to take leave, or maybe not able to participate in the personal events, all these kind of things can lead to burnout of the embryologist and can eventually, if the embryologist is stressed, this stress is eventually transmitted to the gametes and to the embryos. So we have to see that embryologists in the lab are not stressed. So we are moving towards more of a kind of automation. So I'm sure this will reduce the stress in embryology and also embryologists. There could be a miniature lab. When we deal with the micro, the size of the sperm and embryos are in the microns. Why do you need a big lab? So whatever the machines we see in the embryology lab today may become obsolete after 10 years or 15 years. We do not know. So we are going from automation to precision and personalization. With all these things, probably the embryologist also will evolve in a new form and will be able to do his or her job very efficiently, causing minimum stress to the embryos. So finally, I can say that the good embryology produces embryos, the stress-free embryology produces healthy outcomes. Thank you very much for your attention.
It was a very enriching talk, very enlightening us about the embryological aspects of fertility. It was very nice, sir. It was a wonderful experience.
I'm very impressed, sir, because as I'm going through your talk and the slides, many of the landmark guidelines and studies, your name is involved. Hats off to you.
Thank you.
I think we realized the stress comes much before the baby is born. Yeah. And what about AI role in this kind of?
Yeah, that's what I stated. AI is, of course, is a new technology, but as of now, we don't have any evidence how it is really going to help us. But I'm sure this will help in selection process, and probably we can probably in the better control of the conditions in the lab, optimization. Definitely, that will have a positive role.
Maybe in future.
In future, yeah.
Very interesting and informative talk.
Yeah.
Thank you very much, Dr. Satish Adiga, for your valuable contribution.